I hope everyone's had a good time at this conference and had fun. I think it's been really interesting, and as a pediatrician who doesn't delve into this area of healthcare, it's been a learning experience for me, plus just great to have all the fantastic people in the room to share your knowledge. We're going to do something a little bit out of the order at the beginning, and we're going to play a game. No, we're not going to play a game. But we did get a couple of requests at dinner last night, and the people that asked for this may be gone. We don't know, but a couple of people asked. Said they had yesterday a request of whether or not we were going to just take a very few minutes to have reflections on the meeting. And this is something, if nobody wants to reflect, we'll move on to the report outs. But this is not a Q&A period, so please don't ask a question. But if you have comments you want to make about the meeting, suggestions, whatever, we're going to keep this to 5-10 minutes at the most. And if we don't have anybody that wants to do this, then we'll move on. But we did have a couple of people last night at dinner said that they had a few people that had requested to just quickly share thoughts about the meeting. So we'll just take a very few minutes if anybody wants to do that. Feel free to come to the microphone. As I said, we're not doing questions, but just thoughts about the meeting, suggestions, for how we can go from here, do better. But I think it's been a very productive day and a half. Anyone want to share any thoughts? Everybody worn out? Yeah, I can think so. Okay, well, if you do, and if at the end, if you want to share with us, that's fine. What we're going to do now is have the 4 groups report out, and we're going to keep the reports. We have an hour, but we'd like to obviously take less than 15 minutes for each group so that we can have a little time for discussion, questions. And I mean, this goes without saying. I mean, this is the beginning of a process. This is not the middle or the end. And so, the things, for instance, I know Judy and her group are doing on the benefits as well as all of the other activities that are spinning here. We really wanted to use this meeting both, one, to kind of get more people in the know of what's going on, but also at the same time give us further ideas. And I think you may know, it's already been said, Hartford supported this group with a grant, Hartford Foundation, and part of their grant, which I think was very smart, was to say you only get half of it up to the meeting, and the other half you only get after the meeting if you have a set of things that you're going to do. And I was asked by several people, I won't mention any names, when we were inviting to the meeting, what's the intent, what's the outcome? And I think, my point is I don't like meetings in general, and I sure don't like meetings that we have just to have a meeting. So our goal here had been to help us, help Santa Fe, help Oral Health America, help others of you who are working on this, to think about kind of what do we do from this point. And it's a moving target, but that was part of the goal, that we actually do come forward as a result of this meeting, and particularly as a result of this morning, with some next steps, ideas, things that we need to be working on. We have a list of deliverables, quite frankly, for Hartford for the rest of this grant for this next year, but that's where's Mike Alfano? Is he in the room yet? I'll speak for Mike. That we've certainly committed to some outcomes, but that can be added to, it can be modified. I think all of us just want to make sure that we can move this effort forward. So just to kind of give a little context for where we are. The first group we want to have report out is the health policy group. That was Ron and Ralph, and I don't know who's going to do the reporting, but we will turn it over to you.
Good morning. We're getting close to afternoon. Make sure everyone's awake. Good. I have the privilege to present out from the health policy. First, I'd like to thank all of those who participated within our group. We had a very robust discussion. I'll try and hit some of the highlights. Those that I miss, my colleagues will definitely fill in for me. So in the health policy group, we decided to look at this challenge within the framework of the triple aim, which carried us into a lot of different arenas. But one of the things that came out of this was the goal is very daunting. and it is a supremely relevant goal to have, but to get to that goal, we have to take smaller steps. It's going to be more effective for us to pick areas of interest that will resonate with our goal and work with others to be able to bring the relevance of oral health into the mainstream conversation. We had a very significant example provided by Dr. Larry Coffey. He gave the example of patients in end-stage renal failure. Under Medicare, they are entitled to dialysis, and they're entitled to a kidney transplant. But the patient that he referenced was not able to receive the kidney transplant because the nephrologist informed the patient that the infection in his mouth was so severe that it would result in a failure of the implant. This was a surprise to the patient. It was even more of a surprise that he had no access or means to have his oral health improved. Luckily, Larry's group was able to provide that benefit for the patient. That patient later received a kidney transplant. It's those types of stories that make our cause real. That was one of the major things that came out of our conference, our conversation, that struck me as a beginning point for us. In that it's not so much what we can bring to the conversation in terms of how valuable we are, it's what can we bring to others' conversations that helps them to move forward in their endeavors. In looking at our current state, there are opportunities for us to provide care to the elder through other means. It was brought up by Jeff Album that the exchange offers plans that are in the price range that was suggested to us yesterday, but yet seniors are not allowed to purchase those dental plans on the exchange. Those are areas where there is an immediate opportunity for us to have an impact by demonstrating that need in a lesser environment. It gives us more strength to bring that conversation to a broader audience. So the takeaway for me was that we need to start by going outside of ourselves, taking our message to other groups. It was not lost on my group that the board of the American Diabetes Association is meeting in this building at this time, and yet they're not part of our conversation. It was suggested that we form a task force that takes our message to their meetings as opposed to expecting them to come to ours. So we have to get outside of our own comfort zone and look to others to help us move this forward. Someone mentioned we should hook our wagons to a moving train. So it's very important for us to look outside of dentistry to see where there is momentum, where there is the opportunity to partner, and where we can bring something to the table. In regards to cost, it was also brought up that we should look at our offering as a cost savings, not so much as a cost for the system. By doing that, if we partner with others, we can demonstrate that by providing oral health benefits, we can help to reduce cost in other areas. That has a better resonance than to simply say it will cost $500 million for us to provide care. It's what do I get for that care that we're providing. So in summary for me, it's incremental steps, partnering outside of ourselves, working together with others to move forward an entire health initiative that includes oral health, starting with examples that resonate with the public, that are real life examples, and using those as our springboard to gain more attention.
In everything that Ron covered, I want to echo just the appreciation of how much policy expertise actually was in our session. There are a lot of people who have been doing this work, and as you get to come in from your other sessions and talk with them, I hope you'll gain some of that. There's this emphasis on who's at the table, who's in the conversation, what infrastructure is needed. I just want to say a word because several people have asked me to do this, both in our, after our session and then in the halls. So in the idea of who else is going in a direction that's not us necessarily, in other words, the dental or oral health community, what you have around your neck, and I guess they've been shy, there are people who are national leaders in the Oral Health 2020 National Network. It's a large group of people, and there are reference individuals, there are people on the national coordinating team of that. Could you raise your hands here? Several of you are on the working on that. Maria Dolce, I think Beth, I think Ann, you've been involved in that. Talk to folks about how that's working, because I think there's a people's movement that some of us know about and some of us don't. So I just wanted to add that in terms of if we're in a policy space where we need to get a lot of people to the table or around the protest line, they're there. Okay? Thanks.
Any comments, questions? We don't want to replow ground that's been plowed over the last day and a half, but any other questions around the issues that have been raised by the health policy group? Okay, and we'll also probably have a little time at the end. I don't think we're going to be rushed for time here. Health economics, who's going to report out for that group?
Well, good morning, everyone. I want to thank the group that attended our session, and I'm presenting this on behalf of the group leaders. Peter Dubois couldn't be with us today, so I'm filling in as Peter, and Gary Price is in the back of the room, and Jean Calvo is our recorder, and Jean took copious notes to help us move this forward. And we had great participants in our group, and I'm going to use an analogy that I used during our session. In some ways, as we were attempting to lead the discussion, I felt like the air traffic controller. And we had lots of planes flying in a limited space, and everyone was passionate about their assigned altitude. And we were flying over each other and under each other. And maybe the most important thing that happened is we had great conversations in a very multidisciplinary group with a tremendous group of passionate dentist advocates, dental professionals, and health policy people who perhaps often don't know how to speak with each other, and maybe are saying the same things but using different languages. So I thought that was really maybe the best outcome of our session today. We had a debate based on principle about who should and who should have this dental benefit. And so we do agree that we need additional work on determining some fundamental principles. Should this be a universal benefit, those directed towards the medically necessary, dual eligibles? Is this an incremental approach or a big bang approach? And so those are some examples of some underlying principles that would need to be established in putting together a coalition. Again, we need to learn to talk with each other and work together, be clear on principles, and work probably at the same time on several different fronts. We were really supposed to address economics and plan design, and I want to commend the group that put together the plan that was presented yesterday, and they may be a little disappointed that they didn't get more specific feedback about that plan design. Although some of the feedback was very useful about perhaps working more closely with CMS and then the opportunity to work with our Medicare policy experts on whether this should be a Part B initiative, a Part D initiative, is it an insurance product, is it a reimbursement model? Are there innovative ways to design the plan? And so those were kind of the big picture questions, in addition to the deeper dives on, is it a preventive benefit? Is it a restorative benefit? What do you do for dentures? How and when, or how often would you replace a denture? Those kinds of questions. We recognize the real importance of building demand, the need for stories and data, and creating this excitement, enthusiasm, energy around this issue. And I think that's clearly illustrated on that diagram as well. The importance of additional research. We thought there was a natural opportunity, for example, with the dental benefit in the Medicare Advantage programs, if there was a way to use those data to really get deeper understanding, expand the evidence base about the value of a preventive benefit in improving overall health. And the need to better understand politics, Medicare, and CMS in general. We recognize this is a multi-year initiative. Again, I've already stated the need to continue to do research, but we need to be able to convincingly demonstrate cost savings, that's an important part of the messaging, in addition to doing messaging research, and build this over time. I thought a really nice tangible outcome of our discussion is, at least after the meeting, several of the policy experts said, wow, maybe we could develop a list of questions that are particularly important to our policy experts, and maybe that can help direct the efforts of our plan design team to say, let's try to answer the most important questions first and use their feedback, one, to improve the dialogue, but also to maybe help direct next steps in terms of the plan design. So that's my summary. If there's anyone in my group that wants to add to that. But thank you for the opportunity. Thank you.
Questions, comments? Gary, would you like to add anything?
I don't know that I can improve on that at all.
Well said. Okay, the third group is the oral systemic connection. Hal, Steve, who's going to report out?
We were a magnificent trio. Elisa and Steve were just wonderful, and we had just a very diverse and intense group of people. And very much like Terry, it was lots of planes flying in the same space. In capturing that, one of the biggest ideas that came out of it is very simple for me to say, and it may take a moment or two for all of us to process, and that is, when you say oral systemic diseases, it implies that the mouth is connected to cardiovascular system, nervous system, endocrine system, but it doesn't imply that the mouth is connected to self-esteem, sense of self, how you're perceived by your family, your loved ones, if you're in an environment. And so we very much would like to consider the behavioral aspect of oral health and those relationships. And I just want to embellish just for a moment, kind of anecdotally. In Los Angeles, we are at the moment dealing with the largest concentration of homeless people in the country. And it is an enigma, and it is overwhelming, and there are all kinds of problems. In 2000, the dental school opened up a clinic with 8 operatories to provide free oral health care to the homeless on Skid Row. And so that's now been going for 16 years. According to the executive director of that, it's called the Union Rescue Mission is the official name, the #1 mental health program that has sustained and is the most talked about is dental. That when people look at themselves in the mirror and they're homeless, there's a certain information exchange, and when they smile and they have a dentition and they can chew and they're comfortable, it's a very different. And that enabling step could have very significant. We're talking about 48,000 people on Skid Row, currently 60,000 people living in Santa Monica, another 28,000 people living in the San Fernando Valley who are all homeless, etc. So oral systemic behavioral connections are real on many different levels. I also wanted to mention that school children are not able to go to school because their teeth hurt. And schools are reimbursed from state budgets based on attendance. So school districts lose money when the kids do not show up for attendance. In Southern California, LA Unified, it's 8% of the student body. The student body is 640,000 kids. It's $53 million a year lost because of toothaches. So there are lots of things that were bubbling up, and let me go over a few with you. One idea that we thought was very compelling is the need for demonstration studies that would be done in diverse locations, maybe 4 or 5 in the country, and we would think of HRSA's, federally qualified community health centers, as a possible laboratory for some. We thought of Kaiser Permanente for others. We thought of a few in the private sector for others, and they would capture the diversity of being older, because all elderly, as all of us, I think, will appreciate, are not ambulatory. So whatever we think about, in part, it's almost like reinventing mobile clinics that Apple Tree has done already in Minnesota as a delivery system to gain access and utilization to folks who live in, quote, old age homes. There's a whole array of people in assisted living at different stages, similar situations. So defining oral health care as an operatory more in the private sector will not address the needs. If there is an oral health benefit, needs to consider going to where the problem resides. We also talked a lot about the issue of quality metrics. Whatever is done needs to be defined, made objective, talked about in a numerical context so that outcomes can be addressed. The issue of cost savings we touched upon. One of the cliches that came up from a few of us were the put your money where your mouth is, which would seem to kind of connect a little bit. The data that exists, that has been gleaned by some very wonderful insurance companies, is very compelling. The thought was it needs to be enhanced a little bit. It doesn't necessarily require the gold standard of multi-center randomized clinical trials, but rather demonstration studies that are analyzed and promoted and talked about, as I mentioned. This is also begging for those places in the country, and there are not enough of them, where there are medical, dental, nursing, pharmacy, physical therapy, occupational therapy, social services connectors, so that those types of organizations can be enormously valuable in moving this agenda. So, had fun, it was productive, and thank you for the opportunity to think about these things. Thank you.
Thanks, Hal. Steve Abel, anything to add? Okay. Anyone else in the group want to add something that feel like we need to was left out? Okay. Last group is oral health literacy, and I see Deshanka here.
Well, first of all, I want to thank Beth Truitt and Bianca Rogers, who helped me with this fabulous group that we had this morning. So all of the oral health literacy participants, raise your hand. We felt, first of all, we started with a conversation of what oral health literacy is. Alice Horwitz gave us a 101 and referred us back to the IOM report so that we would understand the comprehensive nature of oral health literacy. I would say in a nutshell, our discussion, which took place to take a look at which stakeholder groups would be most in need of enhanced oral health literacy in order to move this issue forward that we've been talking about for the last day and a half, whether it's providers, policymakers, or consumers, gave us the structure in which we could see where our pathway is. But oral health literacy overall, the way that we were looking at, transcends everything that we have talked about in all the other groups and throughout yesterday and today. So the group in particular identified, of those three stakeholder groups, that consumers were the highest priority in terms of enhanced oral health literacy, and no surprise there that education was seen as a centerpiece action, but that needed to come with funding, with messaging, with outreach, with actually working with the leaders in the community that are peers that could really take that message forward, and also feed back to those who are working with consumer groups in all categories. So we were talking about caregivers and many different caregivers. We were talking about patients, and we were talking about the communities as a whole. For infrastructure within that group, we felt that it was really important to bring the community leaders forward and funding as well. And then we asked, what are who would actually take the leadership, sort of the way we ended the day yesterday. And for consumers, we had the highest response, obviously, in advocacy groups. Now that became a very broad base. We had asked the question, should it be healthcare providers, should it be social service providers? We were opening up advocacy groups across the full spectrum. And we had introduced some new groups, unexpected advocacy groups and partners, nutritionists, dietitians, technology groups that could play a role, systems groups that could play a role. And these things came up. I'm going to now cross-cut some of the themes that came across as we were going from one group to the other. We then moved to policymakers. And within that particular group, and as you've heard with the health policy group, we felt that obviously evidence-based messaging, but most important was a consistency in the message, a coordinated approach. Leo Rouse couldn't stay for this session, but he was with us this morning, and his mantra, of course, is communication, collaboration, coordination. And I think that those things in any of the groups that we work with are really essential as we move forward. And more with the policymakers as well was the issue of moving to a broader base. And lastly, looking at the provider groups, that's where we were looking across all provider groups, both in the health professions, but also in social service and education provider groups. We definitely focused on the interprofessional aspects, so it's not just enhancing health literacy within each of those silos, but using it as a bridge across the different professions. We felt that it was essential to get health literacy expertise within these provider groups, but also making sure that we're linking the fact, we talked a little bit about cultural competency, that cultural competency and health literacy are connected at the hip, and that we need to have those two efforts intertwined. A lot for provider groups was looking at standards and toolkits and not really easy ways, but ways in which we could digest messages and implement practices that would really be able to reinforce and enhance health. And actually, we of course felt that oral health literacy is the world, and we were going from in utero, Hal would like that portion, or preconception, probably even better. But all the way through the lifespan. We wanted to see it integrated back in our schools. We wanted it at Head Start. We want to keep it all the way through so that we're not having to fix things later on through continuing education alone or any kind of standards that would be gatekeepers, relicensure requirements, etc. So in a nutshell, I think that we saw sort of similar themes for actions for our leads, as well as for the infrastructure in this area, whether it's any one of these stakeholder groups. And I think we sort of reinforced at the end the importance of a group that can come together that could bring these different perspectives, where we could have respect and trust for one another, but also be able to come up with some common messaging. And I like the comment that was made with the American Diabetes Association meeting. We talked a lot about disease-specific groups. We talked a lot about very broad-based advocacy groups as well. So I welcome our group to add to this, and I want to thank them. And we did document the richness of the conversation, and we learned a lot of initiatives that are already on the way. So we are all following a very similar path. Any comments from our group? Thank you very much.
Thanks to Shanka. I think most of you know, but we did, as we've already alluded, have recorders in each one of the groups. So we wanted to capture the discussion. So even though this is a brief synopsis of what went on in those groups, we will be getting more detail from the recorders. The other thing you may or may not be aware of is also we have a health writer that'll be putting this meeting together in a kind of a proceedings, which we plan to publish after the meeting. The other thing that you have seen, I'm sure, is we're videotaping everything almost. And we plan to take the videotapes from this session, from the sessions yesterday, edit those down. We've been doing some individual recordings of various members of the speakers and others on this issue of senior oral health. Our plans are over the next year, over the next several months, to edit these down, to use them in a variety of ways: webcast, educational opportunities, social media, of which I don't totally understand, so Nick and his cohorts have to tell us how we're going to do that. Poor Claudia has tried for 4 years. She worked for me for 4 years before she came on with Santa Fe, and tried for 4 years to get me on Twitter and didn't fully succeed, but it was a great effort, Claudia. But anyway, the point being that this is not just done. We plan to repackage this. I think there's a wealth of information that's occurred over the last day and a half. And for any of you that have organizations, opportunities where you think that bits and pieces of this can be used, we would love to do that, because we want to share this to the broader audience as much as we can. So I think there'll be some opportunities to do that. The last thing I want to say before I turn it over to Mike, as I've already said, this is, the whole intent was this, to both get together and get our best thoughts on this issue, but then to really use this as a springboard to do next steps. And so a lot of good suggestions. I've had several things that I thought of the beginning of yesterday and today that I should have thought of months ago, that I really feel badly that I didn't think to include in this meeting. But we solicit your suggestions on how we can get this into the broader audience, how we can, through health literacy, get this to be a topic of the community, not just a topic of our professional association. So there's a lot of work to be done. The thing that came to mind as I was sitting there listening to everyone is that the quote by Margaret Mead that said, "Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has." So that's us. Mike?
Thank you, Earl. A person of my girth should never walk in front of a projector like that. It reminds me of Alfred Hitchcock, and many of you are old enough to remember the Alfred Hitchcock show. And I'm sitting over there saying, why did I position myself here? But again, let me start by again thanking Earl because as you know, he's a person of great stature, and he's been helpful not only as our leader in pulling the conference together, but also in terms of opening many doors for us along the way. So we really we owe you a debt of gratitude, and I want to thank you right up front. So, how do you summarize a meeting like this? It's pretty difficult, and I'm only going to scratch the surface and sort of remind us of a few things that went on, and then maybe spend a few minutes about next steps, both what we're currently thinking and also what we should be thinking based upon the feedback we got today during this conference, and that I may hear before we, put the lights out. So we tried to organize this in the terms of the need, the value proposition, the benefit, the consumer. I think if I was reflecting on it again, I would add the mix. Because in the beginning, while Santa Fe knew it wanted to recruit a decidedly different group of people than it typically recruits to a meeting, we didn't have a clue if we would be successful. So our hats go off. Is that a mixed cliche? Hats off, hats out, arms out, whatever. Insert cliche. To those of you in the, I'll call it the consumer services, the consumer advocacy sector, that responded to an email from an organization that you probably didn't have a clue who it was or what it was doing, and you looked at the agenda and said, this is a meeting we want to be at. And so of all those categories, maybe the most important thing that's happened is to the catalysis of this mix of people that need each other if we're to be successful on this agenda. So thank you for that. We heard, getting back to the need, Dr. Jones, Mansky, Chavez, and Dr. Vujicic also talk about need in different ways. They dimensionalized it with numbers based on income, and at times they tried to touch your heart with the case histories of some patients that had been seen. It can be very valuable to a cause. Example, I was once sitting on an FDA review committee, and it was on the safety of APAP, Tylenol. And it's, by one level, by one dimension, one of the safest drugs ever made. But it does have a serious side effect that most people don't know about in certain individuals. And so the scientists sitting around the room had reviewed the data, how many X billion doses of Tylenol per year, and we're rapidly moving towards a course of sort of approval, keep the same label. And then about a dozen parents stepped up, and they showed pictures, of their kids that died because Tylenol is in everything. And you don't realize that. It's in cold preparation, it's in narcotic preparations, it's in over-the-counter preparations. And so story banking needs to be a part of what we do. The rationale, value proposition, Drs. Lamster, Jacobson, and again, Vujicic. And this was interesting because we had the yin and yang in play. There's part of at least the dental folks in this room that want oral health to be important to body health. It is the body. And we often say, put the mouth back in the body. You've heard that before. And we shouldn't have to be obliged to justify we should do this because we can pay for it. And yet, we do feel obliged, particularly in this environment where financing is so difficult. And it was it was enlightening to see that this group, in a sense, acknowledged that by virtue of emphasizing medically necessary care. So that was a revelation for us, to basically understand that we are going to need to pursue a value proposition if we're to be successful. The benefit was very interesting. So we got the big picture from Dr. Oberlander, and then Dr. Jones, who does double duty for us all the time, talked about our initial thoughts on benefits. And Dr. Chafin, of course, expanded that to point out this is a different population, and traditional thinking might not give them all the services that these individuals in this age category need. But the great part about that discussion was the realization, I think it was, I might get his name wrong, David Lipschitz. Did I get that right? Okay. I tried to get to see you, but I couldn't get through the crowd. But in a very nice way, opened our eyes to our naivete in terms of understanding how the Medicare system works. So thank you for that, and we'll be talking to you. We don't want to stumble and bumble our way with the benefit building. You know, we were sensitive to how is the dentist going to see it. We were sensitive to try to build a benefit basis, as Judy said, that would be attractive to dentists, because what's the point of building a program that no providers want to participate in? You know, you just make it worse because you tease people, and they don't really end up with the benefit that they should have. We also push back on premiums. We need to think whether and how, you know, there should be premiums. So much work to do there. The consumer, we only scratched the surface, and someone said to me, you know, you really gave short shrift to the consumer issues. And we did. We knew that. We knew that going in. Our mistake was not to tell you we're giving short shrift to the consumer issues. We basically included a section for a couple of reasons. One, we didn't want you to think we were ignoring the need to communicate throughout the course of what will probably be a campaign, and also because it was an important part of our partnership with Oral Health America, and it's a part of the partnership that Oral Health America took the lead on. So you could do an entire conference, of course, on how to manage that consumer messaging. So, next steps. This is only preliminary because we have yet to come together. So in the short term, we have a number of things already lined up to do. Research America, with support from Colgate, is doing a congressional briefing on Tuesday. Some of us will participate in that, and we will be talking about the results of this conference. Research America cleverly scheduled that when, you know, Congress is now closed, they're campaigning, but the staffers still work. And so we get the staffers to come out and try to educate them. American Dental Association has a symposium scheduled, also pulled together by Colgate, at which, among other things, this conference will be discussed. Colgate is also sponsoring a special issue of Scientific American, which will be distributed for the first time in small numbers, but then to be rolled out at the ADA conference. So more news about oral health. We have submitted a proposal that's been accepted to present a summary of this meeting at the American Dental Education Association in March. And we will be continuing our dialogue with CMS, especially CMMI, and we may well be calling on many of you to help. We've already started to do that, actually, in terms of inspiring CMMI to request proposals that will provide additional data that will both convince the CMS itself and perhaps the Congressional Budget Office that there really is merit to this cause. Longer term, it remains to be seen what the coalition will be, how it will come together. We talked a little bit about that, you know, who should be a lead organization, because I really do think it needs to be coordinated, and I do believe an organization will rise. We talked about AARP. We talked about Families USA, and we'll have to see how that goes. We know it's not going to be the Santa Fe group. That's really not what we do. And then we need to come to a decision about what that coalition does and what kind of priority does it set. So at one level, there is work going on, and there's actually a submission before CMS to expand the definition of medically necessary dental care. This is an initiative of Larry Coffey and the Center for Medicare Advocacy to say, you can't limit it only to people with essentially head and neck cancer and irradiation related there too. You need to expand it, and you need to be able to allow for people to have kidney transplants and the like. Certainly worthy cause. This is serious medical conditions that are life-threatening of an immediate nature, as opposed to diabetes and heart disease, which are also life-threatening, but on a more chronic timeline. Santa Fe has been thinking about doing a benefit for all. So, for example, while we sent the Avalier report to you, I hope you've had a chance to look at it, it shows very powerful numbers. You can take issue with how the numbers were done, but they're not unreasonable. But it cherry picks, and so at one level, it only provides a dental benefit that is limited to essentially eliminating inflammation, essentially periodontal therapy, prevention periodontal therapy. So you diminish the total cost to the program. And on the other side, it only offers that to individuals who have those conditions we talked about, something like 35%, if you sort of group them all, of the of the Medicare population. So you get great numbers when you do that, but so far at least Santa Fe has been more on the righteous side of the curve, that we need to provide this for all people. However, I got a note last night from a very sharp attorney who knows his way around DC. Is Eric Berger here today? Okay. So Eric said, I think you might want to take an intermediate lift and consider going somewhere between, I'll call it the Larry Coffey initiative and the full bore Santa Fe initiative, and expand it for medical need, but medical now includes diabetes, heart disease, end-stage renal disease, et cetera, because it fits within the jargon of what CMS is now doing. Thoughts about that?
So I should share a story. So back in 1996, Bud Conklin, who was then president of the American Association of Hospital
Back in 1996, 97, Bud Conklin, who was then president of the American Association of Hospital Dentists, and John Rakalkas, who was executive director of special care dentistry, wanted to do a cost assessment to help Representative Steny Hoyer write a bill, which was the medical necessity oral health care bill. And so we actually did define 4 disease groups. I helped with this, which is how I know about this. We defined 4 disease groups, met with CMS, and then, and I don't know if it was the Congressional Budget Office or if it was another federal group, but they did that cost analysis that Dr. Oberlander said yesterday. And the cost, of course, was just astronomical. So again, I think it's worth considering, but we have to also keep in mind that that's a serious part of the process, where the CBO, as Marco said, they look at these things dispassionately. So I think we should, but again, I think that modeling probably needs to be done so that we don't go in with this and then basically shoot ourselves in the foot.
Fair enough. And I want to be fair to Eric Berger also, because he wasn't saying don't do the fully flowered program, but you might try to get that and get nothing, whereas if you go intermediate and you have the success that you think you're going to have in terms of savings within the program, then it becomes easier to extend. And here I'm deferring to his expertise in working with Congress. Beth?
Yeah, I've been impressed also with Eric's point of view that medically necessary is not one and done, and I think there was some concern about that. If something like that is passed, then do we have a situation in which to say, well, okay, we took care of that and move on? But I think that these steps can really be part of the education. Because as we take those steps and have successes, then those successes become part of the story. And so I think from that perspective, having been involved with you throughout the year, thinking through this whole thing, we shouldn't ever move away from wanting to get the whole thing done, but to realize that steps along the way may be one of the most powerful things that we can do.
Okay. Dr. Donoff? I think you need to get to the microphone.
One of the summarizing speakers mentioned an anecdotal story of a nephrologist canceling a kidney transplant because of infection in the mouth. I would ask, what's the evidence for that? Because for years, we've been dealing with subacute bacterial endocarditis. I'm old enough to remember we used to give 4 days of preoperative antibiotics, then 2 days, then 1 day, now the morning of, and that's it. So as you said earlier, or someone said, sometimes all the evidence isn't necessary to make the case if it's made with the right people.
Fair point, but I can assure you the case is real. I've actually seen a picture of the family.
What's the evidence?
That I don't have. That example is a real example. Any other comments before we move to a close? Anybody? Anybody? Yeah, yes, Dr. Moradian.
This is just something to get on people's radar screen. The paper that was in the handouts that's going to appear in Generations magazine, I don't know, is Michelle Saunders still here? Yeah, here she is. That's coming out. That's the Journal of the American Society on Aging. And Michelle Saunders from San Antonio is the guest editor, and the entire issue is going to be on oral health for the elderly. So would encourage, it's coming out in November, is that correct, right? There are several other papers in it by others here, Judy Jones, I have a paper there. And so the American Society for the Aging is sort of intermediate between the in-group and the much larger consumers. So would encourage everybody to pick up on that and just not to forget that point.
Thank you. When we used to close out the Senate meetings at NYU, our president used to say, is there anyone else with an irresistible urge to speak? And at one of the meetings, a student arose and she said, Mr. President, I have an irresistible urge to speak, but I don't know what I want to say. Not necessarily proud that that was one of our students, but and from our lead sponsor.
Hi, I'm Ronnie Snyder with the John A. Hartford Foundation, and this meeting's been really exciting, and I think the example of the JAGS journal that's coming out dedicated to oral health is just one of many examples of why this issue has traction right now and how it has traction. I've been taking notes throughout the meeting because a lot of this is new content for me in terms of the oral health perspective. And the note that I took this morning that I highlighted for myself because I really think it's been repeated in various ways or implied in various ways throughout the 2 days was look for cost savings to demonstrate that providing oral health benefits will provide net savings to the system. And I think that's enormous, and I think that's where it's at. And I can give a couple of examples from our funding of where various programs have been able to do that, and there are new benefits to Medicare coming in the next year. So one of those is a diabetes prevention program from the National Association of the YMCAs. And they were able to demonstrate that this diabetes prevention program saves money to Medicare, and it will be a new benefit next year. Another is very important, the Independence at Home project through CMMI that has shown that home-based primary care saves enormous amounts of money to the system. And there will be additional funding for home-based primary care. So I think the time is now. I don't think it's different for oral health, and I want to kind of just raise a fist to the charge that I think you can do this. I think you should think big. This is really exciting.
Well, thank you very much. One second. I'll use this time to actually thank our lead sponsor, the John A. Hartford Foundation. You know, some of you may think that, well, wink, wink, you know, Terry Fulmer used to be part of the Santa Fe group, and wink, wink, she has authority to sign a check. That's not actually the way it went down. It was Terry's decision that we had to go through the full review, and it had to pass the board. And I thank her for that because it made us do a better job. That's number one. Number two, Terry also said, what's your follow-up? And so while we're asking for a grant for this conference, we now have a second grant that will be coming from Hartford to support some of this follow-up work we're going to need to do. So, and then she comes and keynotes. So thank you very much, Hartford. Yeah.
So this is a story, not my story, but I relate it and share it with you in that Hirsch, my husband, his first assignment when he went into the U.S. Public Health Service was to go to Kansas City. He was in the Division of Dentistry. Most of you don't even know that existed, but it was pre-HRSA. And he was there to actually assist Stan Lotzgar, who was making a movie. This was in the 60s. The movie was on dental care for the elderly, and it's called The Vigil of Jenny Fay. And I would urge you, it's now housed at the National Library of Medicine. And if there's any way you can hook up this conference with that video, it shows how long this has been a problem. We still recognize it, but now we're going to solve it. But this actually gets into visiting in homes for the homebound. And it's really, it will not win prizes for cinematography, but it is a real tearjerker, just as our situation is today.
Is it on the web?
I don't know if it's on a web, but I know they have now transferred it to DVDs, so I'm pretty sure they would share it.
Okay, great. If you could send me the contact information, I'd appreciate that. So, time for the thank yous. We've already thanked our lead sponsor. We also need to thank, once again, I'm not going to list them, our special sponsors for this meeting, and our regular sponsors, people who give the Santa Fe Group money so it can exist from year to year. We call that our Founders Fund, and it helps us move forward. And it's very important, and the reason it's called a Founders Fund, because our founders have started dying. And so we would like this initiative to go on, and it takes money for that to happen. And so fortunately we have a bit of a head of steam. Not that the two founders in the room are Hal and me. So, yeah, good. And since Hal opened his keynote at NYU a few weeks ago with, I'm a 78-year-old sexually active man, I thought this broader audience would want to know that as well. So thank you, sponsors. And by the way, the sponsors didn't just give us money. Most of them actually were here at a very senior level, including chairman of the board and CEO level. So that says more to me. It's easy to write a check for whatever, 25 grand, believe it or not, for these large corporations. But when they give up their time, that's really special. And so thank them for that. Also, Aegis Communications has spent most of the day yesterday picking people to interview. I think they ended up interviewing 14 people, and some of that is already up on their website. They say they have enough video to pump out new information for the next week. So it will keep this in front, at least of their population, and they have several dental journals that they publish. So thanks to Aegis Communications. Shine, in addition to being a monetary donor, provided the audiovisual support that you saw, that you're seeing right now, but also for some interviews that Santa Fe group members conducted in a neighboring room. And of course, the purpose of that is to have material that people end up, finding. They'll search on a person because they're interested in whatever, Center for Medicare Advocacy, and they'll see someone, a video of someone talking about this conference. So you get that sort of serendipity kind of connection. Dentsply Sirona, in addition to be a financial contributor, set up the registration website. You may have gathered by the plain black folders and the simple ID badges that the Santa Fe Group is not a fancy organization. We have no full-time employees. We have 2 part-time employees, and they do a great job. They're not in the room, but I want to thank Marian Jakubiak and Julie Thomas. Those are the 2 ladies you've seen outside. Julie actually does not work for the Santa Fe Group. She's a gift from the Dental Trade Alliance, and thank you, Gary Price, because she did a great job for us. And finally, I want to make a comment, just a couple words about the American Dental Association. The American Dental Association was here in force, and not just in numbers, but in seniority. So there's Carol Summer Hayes, who opened the meeting for us, still here, still staying the course, busy lady to be sure. But we had the executive director, we had Carol, we had trustees, we had vice presidents of the ADA. What I admire about their appearance here is that it takes an element of courage, because the operational structure of the ADA is that the House of Delegates sets policy. So anytime you see a leader, trustee, stepping out and getting in front of an issue like this, when the House of Delegates hasn't voted yet on what their position is, it's a sign of great courage. So we appreciate that leadership, and we know they can't hurt you now, Carol. Thanks for being here, and we do hope that the House of Delegates we do hope the House of Delegates makes the right call ultimately when it gets to them and is part of this coalition, because the ADA is a very powerful ally. So thank you for that. Finally, I thanked Earl, the planning committee, comprised mostly of Santa Feans, but we had some outside folks because we wanted to add some diversity. And I think if we were to do another meeting like this, we would have even some different people than we have had. But Mike Monopoly from DentaQuest, Lynn Mouden, a special shout out. We thanked Lynn for all his help with CMS yesterday, but I'll thank him again. Mary Foley served on that committee, and also Beth Truitt. So a labor of love, I think, for all of us, a worthy cause, and a very special moment, because dentists don't often interact with such a diverse group. The nurses help get us started, in this diversification, but the policy folks stepped up as well. I don't want to forget our colleagues from dental hygiene, who are also here at very high levels, and I believe will play a role, particularly as this issue of expanded services works its way through the states. And so that could be very helpful in terms of delivering care if lots of people become eligible for care that aren't getting it now. Ladies and gentlemen, thank you so much for coming.